And meanwhile, I will already present our next speaker. His name is D Gerber, and he started as a VTA fellow in 2018, and now he's specialized in congenital heart disease. And as the member of the transfusion board of the Inselspital in Bern, and with special interest in evidence-based medicine, he tries to answer the question today: how much is just fine with red blood cell transfusion?
Well, actually, I'm coming directly out of a case with aortic dissection type A in an old lady, and that was stable in the emergency room, but the emergency physicians called up on red blood cell transfusion as soon as they discovered the anemia with 88 grams per deciliters of hemoglobin. And had a quick discussion there, and I think maybe kind of some aspects of this discussion can be useful to you as well. And it's a rather old discussion, although this paper is already nearly 25 years old, from North America, where they studied 24 institutions that sent their data in for evaluation of the transfusion incidence during cardiopulmonary bypass or for operations on coronary artery bypass surgery. And this was a rather astonishing result, as there were some institutions with a transfusion incidence of about 27% for their patients, and other institutions went up to 90% or over 90% of their patients had a transfusion during this surgery. And now, as a anesthesiologist, it's always easy to blame the surgeon or to blame the perfusionists for techniques or mishaps that lead to transfusion. But this was already seen here, that there is a group of low blood loss, but nonetheless high transfusion centers. And the same can be seen here in this work, where it's just one center that looked into the data and saw that, in fact, if they correct for all the baseline influence factors and also the perioperative influence factors, there are not that big differences between each surgeon, or with a odds ratio for transfusion of about 1 and a bit lower and a bit higher, or for the perfusionists. But those who are causing big variability seem to be the anesthesiologists. If you're treated by anesthesiologist number 4, you're the lucky one with not that much transfusion. And if you happen to be in the hands of anesthesiologist number 1 or 2, your risk is more than doubled after correction for all other factors. So obviously there is some variability in there, and this is clear. If you have any intervention threshold, maybe for a blood cell transfusion, then most of your patients are hopefully much above. Some of them will be below that intervention threshold, and the area under this curve is always the highest, just above and below the given threshold, and there is where much of this variability happens, and you have other factors that come into place here. One issue of variability is depicted here as well. Obviously, we have different preferences for transfusion and target range. That's over 50,000 patients from one center in Canada. And again, here you see, well, it depends on your surgery that you're having, whether the goal is low or high, and it depends on your surgeon, and it depends as well on the anesthesiologists, on whether they transfuse at the high, or at the high here, or at the lower level of hemoglobin. So obviously your own preferences have a role in here. Then we're known that we're not that good at the assessment of bleeding. These are preclinical data where lay people had to estimate blood loss, And for small blood losses, that was overestimated. And for higher blood loss, there is a large estimation of blood loss. And it doesn't get better if you're a bit more professional. Paramedics, Boyle and Williams came to the conclusion, in fact, this visual estimation is too inaccurate to be of any clinical benefit, and it's not related to your experience. And the same has been shown also for emergency physicians. And my fear is that the same would also be true for our own assessment of bleeding in the OR, that we're not that precise.